Yep.
So good gait analysis going back, observing the subtalar joints, her femoral rotation, good, her full stride follow through. Okay, go ahead and stand up, turn around all the way. And I like to check the hip and pelvis. And the knee is a two-joint muscle, it has a lot of two-joint tendons involved, so you want to check the hip and pelvis. And so we bend forward, touch your toes. Going back up, checking for abnormalities, bend back, straighten up, stand on one leg, checking for the other leg, always check the glute medius for strength, has a relationship with the VMO, medial quad muscle. Lay back on your back up there. Going into obviously the inspection, palpation of the knee, the observation, check passive range of motion, full motion. Obviously we're going to elicit a history before the exam. I'm going to check for, again, any atrophy or signs of, someone's been dealing with pain for a while. We'll look at the medial quad muscle. Okay, look for any deformities, long-standing arthritis, may show some deformities in the bone. We're going to have done already another hip and pelvis exam lying down, getting into the knee itself, do an apprehension test, almost a grind test. Sometimes people with tracking issues have a problem with that. Again, crepitus. Sometimes we'll pick up a plica on palpation. Going into provocative, I go into the ACL, Lockman, check that's stable, move that into McMurray's meniscus. I go right into my valgus testing for MCL. LCL is a figure 4, filled with a lateral collateral. Neutral foot, sit, anterior drawer for ACL, posterior drawer for PCL. If it's a significant posterior injury, look for a posterior lateral corner injury, no laxity. Staying with the PCL, you can do it for a sag sign. You can always compare it to the other side. It'll show a sag. If it's another posterior lateral corner, you can do a dial test. If they have extreme tibial rotation, greater than 15 degrees, usually that's another sign the posterior lateral corner was injured. And you can also finish up. It's very difficult to do it is doing a pivot where you provide a valgus and the internal rotation of the tibia. More easy to do on the field and in the OR. So you're going to get a good neuro exam as well. So it's the knee. Okay. Ankle exam, again, another gait analysis. Looking at the subtalar joints. Looking at her femoral alignment, hip alignment. Looking at her hip and pelvis, how she carries that. Go ahead and have a seat up here. I always start my ankle exams at the proximal tib fib, ruling out any fibular injury, especially with an external rotation, eversion type of injury. They may have a fracture, so if they have any pain, I move all the way down. Squeeze test, sometimes a syndesmosis, high ankle sprain. And again, I'll have them do active and I'll check passive range of motion and dorsiflexion, plantar flexion, inversion, eversion. I'll get to the ankle itself at the end. I'll check the first ray mobility. Is it hypomobile, navicular tenderness. Okay, check for the cuboid and fifth metatarsal tenderness. We'll see fractures, stress fractures there. Check the talus, make sure there's no tenderness. Talus is an area you can get stress fractures and occult osteochondral lesions. You've got your 3 sets of ligaments here for ankle sprains, your deltoid ligament for medial ankle sprains. You can check for motor, sensory, and reflexes. And, so we do a external rotation, which is a talar tilt. Greater than 10 degrees is a positive sign. Anterior drawer, 10 millimeters. External rotation, stress test or Cotton's test for a high ankle sprain, syndesmosis sprain, and a deltoid. And to the foot, described some of that already. You can have neuromas, stress fractures along the second met. First metatarsal can have a variety of things like gout and hallux rigidus, or arthritic conditions that can cause that. Bunions can occur there. Metatarsalgia along the balls of the foot, the bottom. So, okay. Good. So I ever sit up first, do an anterior exam, inspection, look for any atrophy, deformities. Okay, have them do a general active range of motion. Put your hands like this, like that, this, behind you. That's all within normal. If it's not, I'll check passive. I'll move into some general rotator cuff and go ahead and push up against me, a Hawkins maneuver. Knees. And then keep your arm up, thumb down, empty can. Okay, squeeze my hand, do a dumbbell curl, Jorgensen's with a little supination, keep it up, don't push down, speeds. Okay, I'll move into some of the labral testing. Go ahead and keep your thumb down, push up. Now go ahead and supinate and bring your palm up, and then we'll see if there's any pain with either that. That's O'Brien's test, make a muscle, biceps load. Checking the labrum out, specifically the labral bicipital attachment. And then I'll do a side exam, do a kind of a load shift, sulcus sign for inferior laxity, and then we'll do a posterior exam. One up here, stand up and hold. Alright, and then we'll do, I'm going to lift this up a second. Move up. Tank top?
Yeah.
Okay, do some push-ups on the wall. Check for scapular winging. Okay, now look at the medial inferior border of the scapula as described by Ben Kibler. Go ahead and step back all the way. Look for any elevation of either the superior medial or inferior border. Go ahead and put your hands on your hips and bring them up to your sides all the way. And I would feel like you're flying. There you go. I'm feeling for any elevation, abnormalities. That's called the scapular slide test. Scapular assistance test. I'll do is reproduce the impingement. Relax. I'll do an impingement test and push down, and I'm also pushing up on the medial inferior border of the scapula. A lot of times they'll get some relief with that. Okay, go ahead and lay back on your back. Over here. Put your head down over here. So the supine exam, again, check for range of motion, laxity, anterior glenohumeral laxity. We'll see, and I'll compare the affected and unaffected side. Move into a apprehension, which should elicit pain, a relocation. I'll check for a circumduct. We can do a clunk or a jerk test to look for labrum. Just circumduct that labrum to elicit any pain. Okay, good, coming back up. And obviously we're going to do motor, sensory, reflexes, and all that stuff. Okay,